Welcome, my name's Tim Knott. I'm one of the ophthalmologists at the Eye Clinic at Row Referrals in Bristol. This is my personal email address and the address of the team, which is the best one to send general inquiries to, because that goes to all the ophthalmologists and the admin team. And this is my personal WhatsApp number, which feel free to use to message me, ring me anytime. I'd love to hear from you. So today we're talking about identifying intraocular disease in our small animal patients. This is the disease, this group of diseases is the one which we see much less frequently than we see corneal disease, but it's perhaps when missing them can have vital consequences for both the eye and also sometimes the systemic well-being of these patients. So being able to identify intraocular disease and then decide on treatment regimes is very, very important. So what we plan to talk today about is largely anterior segment disease, uveitis, glaucoma, and cataract. And then towards the end of the lecture, we're going to touch on some important posterior segment diseases. But today we're really focusing on anterior segment disease. What do we mean by anterior and posterior segment disease? It really relates to the anatomy of the eye. The eye is a bi-chambered, a two-chambered organ, much in the same way as our heart is a four-chambered organ. We have the anterior segment, which is limited by the sonular fibers which support the lens, the lens itself, starting with the cornea, the anterior chamber containing aqueous humor, the iris, the posterior chamber, the area between the ciliary processes and the back of the iris itself, and those ciliary processes which will produce aqueous humor. So this is our anterior segment. And then the posterior segment is obviously behind this. And the anterior segment functionally is analogous to the lens on the camera, in much the same way as we select the right lens for the right job. We select a long focal length lens with a wide aperture to try and do sport photography. We might have a short focal length lens for give us wide angle photography for landscapes. The species we look after from an evolutionary point of view have developed different lens anterior chamber arrangements to allow them to see different sorts of views of the world. So a horse will have a wide panoramic view of the world, whereas a hawk will have a very complex lens arrangement and a whole eye arrangement actually to allow it to not only see different areas of the world, but also to focus in very, very rapidly during their dive. The posterior segment is the functional part of the eye, the part of the eye which actually takes an image, focused image, and turns it into electrical activity to send it to the brain, and really the retina, which sits like a film along the back curvature of the eye. The fundus will it does that job. The posterior segment also contains the vitreous, has various functions, one of which is at least to help keep that the retina structurally supported. And then the vascular component of the retina, the choroid, which sits beneath the retina, you can see it's this black line here on John Moll's lovely cross-sectional eye images, is the vascular bed the retina sits on and gives it majority of its nutritional support. So the posterior segment is this back part of the eye, and that's analogous to the functional part of the camera, the camera chip or the film itself. And then all the information gathered by the retina is turned into an electrical signal, and that's transmitted by the ganglion cells which are in the outer retina, and then they conglomerate to form the optic nerve and go off to our visual cortex. And this is analogous to the USB cable we might plug our camera into a computer. The anterior and posterior segment disease. So what are the take-home points to remember about the anterior segment disease lecture? The first thing really is when you suspect uveitis, is your first thought should always be systemic disease. In the anterior segment particularly, the posterior segment as well, if you get intraocular inflammation, then that can be the sign of very severe, often life-threatening systemic disease. Glaucoma is a bad disease. Ophthalmologists often refer to it as the cancer of the eye. This is the one medical condition we really struggle with more than any other actually in ophthalmology. The commonest reason to remove eyes. Treatments are often ineffective and are expensive. They involve a lot of dedication and specialist care. So the important thing about glaucoma is to recognise it early, recognise that to get the best outcome, seeking expert advice as soon as possible is the best way to maximise the outcome for these patients. Third point is cataracts. Take-home point is to remember the earlier we operate on these, the better the prognosis. Cataracts can cause lifelong lens-induced uveitis with or without surgery. So long-term management is important as early surgery as well. But the key point really is getting these patients assessed early, so if surgery is appropriate, they can progress as quickly as possible with the best possible outcomes. So uveitis, this is the take-home point. If you see or suspect uveitis, assume there's some horrible systemic disease until proven otherwise. Where do you get the name uveitis from? It causes lots of confusion, particularly in equine ophthalmology, where we use atropine perhaps a bit more in dogs and cats, and in atropinized eyes, we then have to protect those eyes from the sunlight because it can be quite uncomfortable. So there's a lot of clinicians and clients will assume that uveitis is something to do with ultraviolet light, UV. Not at all. Uveitis comes from the term uveal tract, which is the medical term we use to describe the middle ocular tunic layer, which involves our iris, a ciliary body, and our choroid. And it comes from the term uva, which is Greek for grape, and termed by this fascinating chap Galen several thousand years ago now. And he felt when he was dissecting an eye that the inside of the eye, where he peeled away the middle layer, the uveal tract, it looked like a black grape. There's a grape cut in half here, and we can imagine we've got a hole in the front where the stalk attaches, which would be our pupil. The very black skin of the black grape, which is the uveal tract, and then the gubbins, the inside of the center of the grape, which will be our lens and vitreous. And to show what this looks like anatomically, this is a dissection from a dog who's had an evisceration. So as an alternative to enucleation, this dog has kept its sclera and its cornea, has had the eye eviscerated, had its lens removed, had its iris removed, had the ciliary body removed, had the choroid removed, which you can see through the retina here, you see the vessels and the retina. So this is peeled away from the inside of the globe, and a silicon implant, a silicon ball, is placed inside the shell, and that's closed, and the dog retains an eye which can move, albeit blind, and with some long-term corneal issues being common with this procedure. So why we don't tend to do it as a first-line procedure in the UK. So what does allow us, however, is beautiful dissection. So we've peeled away the inside of this eye, and we're looking at the back of the iris here. We're looking at the pupil from behind, and you can see the pigmented epithelium, which typifies the uveal tract, is very dark, and the other side of the iris has no epithelial cover. We're looking straight on iris stroma, but the back is beautifully black. Often you can see this poking around the corner of the pupil from the other side, and then brings around to the ciliary body, which goes all the way around here. And it's beautiful corrugated ciliary processes, and then behind that we've got the choroid, the vascular bed. You can just about see to the less pigmented area of the non-tapetum fundus in this dog. This lovely vascular bed, and the retina itself with this grey folded sheet over the tapetum. So you can see why Galen felt this looked like the inside of a black grape. And that gives us the term uvea or uveal tract. Also, seeing this is all one functional unit, that helps us to think that when we talk about anterior uveitis, and we talk about intermediate uveitis, which affects the ciliary body, and we talk about posterior uveitis or chorioretinitis, which involves the choroid. This is all one structure. So when we see anterior uveitis, we should expect to see inflammation in the ciliary body and go looking for inflammation in the posterior part of the eye as well. So when we think about the uveitis inflammation of the uveal tract, a key point which is different to other organs of the body is its immune status. The eye as a whole is an immune privileged site. That means that there's limited immune cell entry, there's no lymphatic drainage. In addition to that, there's active immune tolerance to foreign antigens, something we call anterior chamber acquired immune deviation or ACAID. This very powerful tolerance system, it helps to avoid intraocular inflammation causing immediate blindness. Obviously, eyes are very important both for hunting and for escaping prey, and we believe that having this ACAID, this limited inflammatory response with intraocular inflammation is a protective measure to try and maintain vision at all costs. Obviously, sometimes we do have to lose vision associated with inflammation. Peter Medawar is a very famous, very talented scientist who looked at this work many years ago now, and he was actually the father of organ transplantation, winning a Nobel Prize in 1960 for his work. To give you an idea, we're all aware of kidney transplants. Kidney transplants are life-saving, life-changing for many people, but the host immune system will try and reject that kidney. That's why we try and tissue manage as best we possibly can. But even with that, most kidney transplant patients will need to be on immunosuppressants for the rest of their lives. In contrast, for corneal transplantation, which is very commonly done as well, because as long as the blood-ocular barrier is intact, has remained intact, and the eye has retained its immune privileged status, then corneal transplants patients need no topical or systemic immunosuppression for the rest of their lives. So it's a very key point. So just touching a bit more on ACA, just to give you an idea of how powerful this intraocular immune tolerance system is. These are some interesting studies from the early part of last century. When we were looking at in vitro fertilization, we were looking at trying to work out how cells develop through the gametes, through the embryo. Researchers were looking for ways to try and incubate these cells in a effective way, and they found that the mouse eggs could be incubated inside the anterior chamber of the rabbit. So a different species, different cell type inside the chamber of a rabbit would actually allow it to develop to a certain point. What they found in their research, however, is that though these cells would be tolerated, there was no inflammation, and they got to a certain point, they would stop at the point that large molecules from given giving hormones to these rabbits, that these large molecules wouldn't cross the blood-ocular barrier to get into the eye. As well as mouse eggs, they've also looked at skin homographs in the brain and also in the anterior chamber of the eye, and it's shown no immune response in these immune privileged sites. This is an aside, I guess. This is talking about intraocular, how the eye copes with intraocular foreign bodies, and this is a mouse cleaver, a very famous Harold Ridley, sorry, a very famous ophthalmologist from last century as well, who was looked after the fighter pilots after the Second World War, and noticed a lot of these fighter pilots during dogfights, the perspex screens would get shattered by gunfire, and small fragments of acrylic would get lodged inside the anterior chamber, sometimes deeper, of these patients. And he noticed that these pieces of acrylic were incredibly well tolerated and caused no reaction inside these patients' eyes many years down the line. And that led him to recognize the significance of this acrylic as a compound which can be tolerated inside the eye, and developed the first intraocular lens, which many of us, if we live long enough, and most of us, if we live into our middle to late 70s, will have had cataracts removed, or have intraocular lens, all thanks to Harold Ridley and what he noticed with his fighter pilots in the Second World War. And the final story to help us understand the immunological status of the eye is a brief chat about sympathetic ophthalmia. This is a human disease, we don't see it in dogs and cats. But a very famous sufferer of this disease was Louis Braille, who invented the Braille system of communication many years ago now. Louis was a saddler's son. He was playing with his father's saddler's needle, big long needle, and accidentally stabbed himself in the eye, and very sadly lost that eye very quickly. But though sad, what was devastating was a few weeks later, that first injury became infected, and during the ensuing endophthalmitis, the circulating immune system broke the blood-ocular barrier, got inside the eye, and discovered for the first time in Louis's life that Louis had intraocular antigens. He wasn't aware of lens proteins, iris proteins, lens proteins, retinal proteins, and following that discovery during the inflammatory process, the immune system then developed a dramatic immune response to those novel antigens. And then the sad part of the tale is that following on from that initial recognition of self-antigen, the normal fellow eye was then attacked by the systemic immune system to develop a blinding granulomatous uveitis, and he sadly lost his second eye very quickly. This doesn't happen in our patients, so we don't have to worry about injury to one eye leading to immune attack on the other. But it does tell us how it helps me to understand how important this separation between our intraocular antigens and the external system, immune system is. So the key to this barrier between the blood, the blood-ocular barrier, is the arrangement of the blood vessels in the eye. So just as the rest of our body, we have capillaries. We don't have very many myoepithelial cells. We do have some. Usually they're just these very simple endothelial cells, and between these endothelial cells, they're bound very, very tightly with tight junctions, these junctional proteins we see at the top left. Now, in the eye particularly, these junctional proteins are there many of them, and they give a very, very tight joining between these capillaries. And obviously, there has to be some gap to allow solutes to travel from the lumen into the eye, so small molecules can cross. But cells certainly can't, and large molecules can't either. And one of the reasons we see, so in uveitis, one of the most potent stimulators to uveitis can be a dramatic reduction in intraocular pressure, so following rupture, globe rupture, for example. And what we'll see in globe rupture or hypotension is as the pressure in the eye drops, then the pressure inside the vessel relatively becomes larger. And we find that these vessels start to swell. As these vessels start to enlarge, these tight junctions start to stretch and snap and allow cells and proteins to enter the eye. One of the reasons we use atropine in our patients is by constricting their iris and the ciliary body back. It scrunches everything together and pulls these vessels back into a tight band in the dilated pupil, and helps to stabilize the blood-ocular barrier by scrunching up these tight junctions. So remember that the vascular arrangement and compromise of this blood-ocular barrier is one of the key points in pretty much all uveitis, not all, but most of them. What does it look like in the acute phase? It's often a red eye, so often conjunctival hyperemia, and it's often a painful eye. We often see miosis or constriction of the pupil. That's a striking sign in acute uveitis. The iris itself might be swollen, or it might change colour, might become hyperemic. It is often painful. We often see anophthalmos as the eyes pull back into the orbit, and often a water discharge and become photophobic. The intraocular pressure is often reduced. The ciliary processes which produce aqueous humour are part of that anterior uveal, the uveal tract, and as they become inflamed, they would tend to reduce, become functionally less effective. We often see aqueous flare, which is a turbidity in the normally clear aqueous humour. We may see blood in the anterior chamber, which may form a large clot, which you would refer to as hyphema, or not necessarily a clot, sorry, a filling of blood from the bottom part of the eye. Later, we see that the inflammatory cells can form together to form exudates, which you would call hypopia, and a blob of pus in the anterior chamber. And then as things change, as the iris becomes very sticky and inflamed, it starts to stick to things. The iris can stick to both the lens and the cornea, we call synechiae, and some of that very highly pigmented posterior lens material can actually come loose and stick to the anterior lens capsule, so we would call a lens rest. This is an example of some cases. There's a horse on the top right, which has got some fibrin and a little bit of pus in the anterior chamber. But strikingly, we've got this bright yellow tapetal reflection because you've got inflammatory mediators building up in the vitreous. So this horse has got both anterior and posterior uveitis. This cat on the top left has got a big blob of fibrin going from the pupil up towards the cornea. Fibrinous uveitis is very common in all our patients. Bottom left we have hypopia, and we have actually pus, this inflammatory cells forming a big clot sitting at the bottom of the eye. Also a very muddy iris. We can't see the iris very clearly due to aqueous flare and a small pupil. At the bottom right we have hyphema. We have blood filling the eye, the blood clot at the bottom, and free blood forming a fluid line going up towards the middle of the pupil. So aqueous flare, what we're talking about is the aqueous humour losing its transparency. We can see that clinically by using a focused light beam going obliquely through the eye while we look at the eye tangentially. So if we observe the eye straight on, and we shine a focus beam of light from a slit lamp or the small circle on our ophthalmoscope or the slit on ophthalmoscope, and we look at the reflections from the light as it hits different surfaces, but also as it examine the light beam as it passes through the eye. The first reflection we'll see will be on the cornea, at the front and the back if you look carefully enough. The second reflection will be on the front of the lens. As it passes through the anterior chamber, you shouldn't see any light because there's nothing to reflect the light through the normally transparent aqueous humor. As it passes through the lens substance, we see a grey line, a grey beam, because the refractive index of the lens is variable as it passes through from front to back. And then we see a reflection of the back of the lens, and they often go off into the vitreous. But really, it's this area between the cornea and the anterior lens cap which we're examining. And if we're seeing a solid beam of light at this point, we would refer to that as aqueous flare, which we can categorize in various ways. With chronicity, the inflammatory mediators, inflammatory cells, particularly floating around the aqueous humor, can start to precipitate on the back of the cornea. And as they do so, they tend to be the bottom of the cornea due to convection currents. We see little tiny, usually white dots, but sometimes grey to black, sticking to the inside of the cornea, includes keratic precipitates or KPs. These are some chronic uveitis. With time, we'll also see the iris architecture will change. It will lose its beautiful almost moon-like appearance with valleys and crevices, and become very smooth and also hyperpigmented. We may see adhesions between the iris and the cornea and the lens. Usually the iris because it's closer, and the lens, sorry, because it's closer. Also, because the iris is so close to the anterior lens, it sits on the anterior lens capsule. It's very common to see anterior subcapsular cataracts associated with the inflammation in the iris. We see other changes in chronic uveitis, particularly in cat. We see lymphocytic uveitis. Lymphocytic uveitis is primarily lymphocyte mediated, and we see the lymphoid follicles within the iris become hypertrophied. See these grey to purple lumps are very common in what we call lymphocytic uveitis in cats. In this cat's also got keratic precipitates sticking to the back of his cornea. Lymphocytic uveitis is non-specific it's not specific to a specific disease. We do see it commonly in chronic uveitis in cats, often where there's no underlying cause being diagnosed, and effectively an immune-mediated chronic uveitis is then postulated as the cause in many of these cats, though not all of them. Posterior uveitis isn't obvious unless we actually look at the retina itself, and what we see, we can't often see the choroid, but we can see the retina which sits on top of it. This is a dog with distemper virus, which has got inflammation actually of its subretinal inflammation here. So what we'll see, the inflammation of the choroid is, as it's so close to the retina, is quite difficult to achieve without retinal inflammation as a bystander issue. So we tend to refer to posterior uveitis as chorioretinitis. There are diseases which are primarily retinal or primarily choroidal in the focus of the inflammation. So chorioretinitis refers to effectively posterior uveitis. We often see hyporeflective, so reduction in tapete reflection as we get inflammatory cells beneath the retina, as you can see in this CBV case. And we may see perivascular cuffing, so we may see white blood cells building up around the blood vessels themselves, particularly in FIP in cats. We may see retinal detachment and retinal hemorrhage. So uveitis, can keep coming back to this point, think systemic disease until proven otherwise. So we'll run through causes of uveitis. So in general, we think of it in two groups: systemic disease or trauma. Systemic disease, any disease which can cause toxemia or bacteremia, can broach that blood ocular barrier and lead to intraocular inflammation. Pyometra being a very common one. If you do farm work, then toxic mastitis would be another one, which could cause. So any toxemic or bacteremic disease, from chronic UTIs, dental disease being another very common one in small animal patients. There are specific infectious diseases, particularly in the cat, leukemia virus, FIV, toxoplasma, particularly associated with FIV, and FIP being the four main ones we would consider, but others as well. In dogs, both toxoplasmosis and neospora can also these migrating migrating toxoplasma and neospora can lodge in the vessels, both in the choroid, the iris, and in the superficial retinal vessels, to lead to chronic granulomatous uveitis, both the back and the front of the eye. And let's say we mentioned pyometra already. Really, the key point is anything which can cause toxemia, bacteremia, microemboli can get into those vessels and damage, expose the intraocular environment to the systemic immune system. And then traumatic causes. I mentioned the hypotension is a very potent cause of uveitis, and the common ones we'd see in practice can be cat scratches, particularly cats meeting puppies for the first time, blackthorns in the autumn, when Jack Russells and spaniels were out herring around like lunatics, a very common cause of sharp trauma. Blunt trauma, RTAs being a common one. The shockwave passes through the eye, it can tear vessels, can get cyclodialysis, where the iris pulls away from the inside of the globe. So this blunt trauma can cause dramatic vascular damage and lead to uveitis, and also extension of periorbital disease. If you've got a mass or an abscess next door to the close association to the globe, then that can lead to uveitis as well. The treatment is really about identification and elimination of cause. So if we have a lens rupture caused by a cat scratch, then removal of the lens material will help, but really the key to long term is to make sure we do that quickly before the immune system becomes sensitized to those lens proteins. Similarly, if you've got a retrobulbar abscess, treating or draining the abscess should lead to elimination. So sadly, even when we remove the underlying cause, we do have to worry about this ongoing potential for ongoing immune uveitis. So even when we can get rid of the initial cause, we do sometimes see long-standing uveitis, and the cats we see with lymphocytic uveitis, many of those probably would have had a systemic illness which led to breakdown of the ocular barrier and self-discovery of intraocular proteins and ongoing ocular-induced autoimmune uveitis even after the initial cause has gone. So identifying and limiting the cause, if possible, is the first step. The actual drugs we use, most powerful toner are steroids, both systemically and topically, depending whether it's anterior or posterior. And often we use both together. And atropine we'll use to stabilize the ocular barrier, but also it will relieve that painful meiosis, which is a big part of the ocular discomfort we see in uveitis. Prognosis is really down to the cause. If a cat's got a life-limiting illness such as lymphoma that's driving the uveitis, then or a lens-induced uveitis, which is we've been unable to, or lens disease, we've been unable to address the problem before the eyes become sensitized to lens proteins, then those eyes will continue to be inflamed for the rest of the dog or cat's life, or have it come to that. So the cause really does dictate the prognosis. Generally, unless it's an acute traumatic event which hasn't damaged the eye significantly, the prognosis is poor. Progression to secondary glaucoma is common, as is cataract and retinal detachment in long-standing chronic cases. That's the end of glaucoma, so we'll take a break and then we'll carry on with glaucoma in a few moments.